You can view previously recorded sessions and TSS talks by visiting our YouTube playlist, and I will put the link in the chat. So let's get started. So today's session is titled Beyond Traditional Risk Factors, Sex-Specific Markers and Mechanisms of Atherosclerotic Cardiovascular Disease, and it is brought to us today by Dr. Matt Nudy. Dr. Nudy is a practicing non-invasive cardiologist at the Penn State Hershey Medical Center, where he serves as an assistant professor of medicine and public health sciences at the Penn State College of Medicine. Dr. Nudy's primary research interest is atherosclerotic cardiovascular disease prevention, specifically studying methods of ASCVD risk prediction and novel ASCVD risk enhancers in menopausal women. And with that, I will turn it over to our presenter, Dr. Matt Nudy. He can introduce himself further.
Yep.
And if you have any questions during the presentation, feel free to use the chat, and we'll be monitoring that for Dr. Nudy.
All right, perfect. Thank you so much, Jess. I appreciate that. I'm using a dual screen computer, so I just want to confirm that I'm sharing the screen with my slides in PowerPoint presentation mode, and you're not seeing like my other screen with the other random windows. Okay.
No, we're just seeing your presentation.
Oh, perfect. All right, sounds great. All right, so as Jess mentioned, I'm one of the cardiologists here at the Penn State Hershey Medical Center, and I'm going to be presenting some of my research on novel methods of cardiac risk assessment in women. And moving forward here, I have no disclosures. As far as the objectives of my talk are concerned, we're going to spend some time just talking about the basics of cardiovascular disease and some of the basics of atherosclerosis. I recognize that not everybody on this call may be an expert on cardiology or cardiovascular disease. We're also going to discuss some of the common risk factors for cardiovascular disease development. We're going to talk about some of the newly recognized risk-enhancing factors for cardiovascular disease, and some of those have an emphasis that are specific to women. And we're also going to talk about how can risk assessment tools for women be improved through the analysis of medial artery calcification and the detection of medial artery calcification. So in its most basic sense, the presentation is going to be broken down into really two sections. The first is going to be some background information and setting the stage. And then the second half of the presentation is going to focus on some of the research that I've been doing and some of the directions that the research is potentially going to take in the future. So since this is the Translational Science Symposium, I just wanted to emphasize where some of this research may fall on the translational spectrum. So it's mainly going to fall in the T1 and T2 area. So I'm going to talk about new methods of diagnosis of cardiovascular disease, new methods of introducing prevention strategies, and a little bit in the T2 realm as well, where I talk about controlled studies, which may lead to effective care. I'm going to talk a little bit less about T0 in the basic science area. I have done some research using animal models to study atherosclerosis, but I'm not really going to emphasize that in today's presentation. And some of the future directions that this research may go may more fall into the T3 area, translation to practice, but we're not quite there yet with some of this research. So just as some background, cardiovascular disease is the most common cause of death in women in the United States and globally, and it's responsible for more than 1 in 4 deaths. We also know that cardiovascular disease death in middle-aged women under the age of 55 years of age is increasing, and it actually prompted the American Heart Association to release a scientific statement recently on that topic. We also know that it's expensive and costs over $225 billion in the United States alone. And we also know that more than 600,000 adults will experience their first heart attack this year. And that would be the primary prevention setting, which we'll talk a little bit more about later. We also know that disparities exist for women in the context of cardiovascular disease. So compared to men, women are more likely to be diagnosed at later stages of cardiovascular disease. They're also more likely to have a worse prognosis following a cardiovascular disease event like a myocardial infarction. We also know that they're less likely to be prescribed guideline-directed medical therapy for cardiovascular disease. And they're also less likely to get invasive treatments like a cardiac catheterization compared to men. This figure here represents cardiovascular disease death in the United States. The red line represents women and the blue line represents men. If you look to the year 2000, you could see at that time, many more women died of cardiovascular disease compared to men. And it was actually right around this time that the American Heart Association introduced their Go Red for Women campaign to try to increase public awareness that women die from cardiovascular disease. More recently, more men have been dying from cardiovascular disease, but since 2010, deaths in both men and women from cardiac disease have been increasing. I just wanted to take a moment to define cardiovascular disease. So cardiovascular disease in its most basic sense is any disease of the heart and blood vessels. And it really can be anything. Now, most of the research that I do and that I kind of focus on is atherosclerotic cardiovascular disease, which is a little bit more specific than just the general term cardiovascular disease. And ASCVD is cardiovascular disease caused by atherosclerosis or plaque buildup in the arteries. And this plaque, as it continues to build up, it can rupture, it can block blood flow to certain tissues, and this can result in a myocardial infarction or heart attack or stroke, or even other diseases as well. And this plaque, it can be fatty, it can be calcified, it can be a mixture of fatty plaque and calcified plaque. And the picture on the bottom right of the screen represents what fatty plaque buildup could look like in an artery. And you can see that it's the yellow area, the plaque, is starting to block blood flow through the artery. Now, before we talk about new risk factors for cardiovascular disease or what's potentially on the horizon, I wanted to take a moment to talk about the traditional risk factors for atherosclerotic cardiovascular disease. So these are defined by the American Heart Association, and these include diabetes, elevated blood pressure or hypertension, obesity, tobacco use, high cholesterol or hyperlipidemia, age, and a family history of premature cardiovascular disease that the AHA defines as less than 65 years of age for a first-degree female relative and less than 55 years of age for a first-degree male relative. Now, the first 5 risk factors listed there are considered modifiable risk factors, meaning that with medication or some kind of behavior change, a patient can alter those risk factors. And the last 2 that are listed are considered non-modifiable risk factors, meaning that unless you had a time machine, there's really not much that you can do to change the last 2. I also wanted to talk a little bit about other factors that are known to increase the risk of atherosclerotic cardiovascular disease that are not one of the traditional risk factors that I listed below or before. These risk-enhancing factors have made their way into our most recent guidelines. So these are now recognized in our ACC/AHA cholesterol guidelines and also our primary prevention guidelines as well. So these include South Asian ancestry, kidney disease such as hemodialysis or chronic kidney disease, metabolic syndrome, which is a combination of being overweight, high triglycerides, and impaired fasting glucose. Pregnancy complications, such as a history of preeclampsia, which can increase the risk of heart failure and also increase the risk of atherosclerotic cardiovascular disease, preterm delivery, premature menopause, which is menopause onset less than 40 years of age. The average age of menopause in the United States is about 51 years of age, and this may have something to do with estrogen deficiency in healthy arteries, which may be protective. Inflammatory conditions like rheumatoid arthritis, lupus, psoriasis, also HIV, and other biomarkers as well, like high lipoprotein A or Lp(a), CRP, ApoB, and triglycerides. I also wanted to take a moment to talk about the stages of ASCVD prevention, because this is important in understanding the research that I'm doing and some of the areas where my research is heading towards. So there's the term primary prevention, and this is the prevention of a first heart attack or stroke. There's secondary prevention, which is prevention of a second or recurrent heart attack or stroke. And there's also a newer term making its way into the literature called primordial prevention. And this is the prevention of ASCVD risk factors like diabetes, high blood pressure, and obesity. And this is particularly important, especially as we're seeing more and more younger patients who are overweight, suffering from obesity, starting to smoke, and even having high blood pressure. Now, when we talk about risk assessment of cardiovascular disease, really, when we're assessing risk in the primary prevention setting or primordial prevention setting. And the reason why we do that is if a patient has already had a heart attack or stroke, if they've already had a stent placed or they've already had a bypass surgery or something like that, we already know that they're at a very high risk. And we already intensify our preventive treatments with things like a statin medication, aspirin, and things like that. Where things are a little less clear is the primary prevention setting. And the question comes up is, how do we identify an individual who's at a high risk of having a heart attack? And how do we identify an individual who's at a low risk of having a heart attack so that we don't have to give them medications like a cholesterol medication? So one of the things that we do is we use a calculator. And the calculator is called the pooled cohort equation. And there's an app for it. And in the clinic, we plug in all of the patient's information, like their demographic data, some of their cholesterol data, their blood pressure data. And it actually spits out a 10-year risk of the patient having a heart attack or stroke. And the overarching goal is that we match the intensity of our preventive therapy to the absolute risk that a patient has of experiencing a heart attack or stroke. So if somebody's really high risk, we may be doing lots of things. And if somebody's really low risk, we may just be recommending exercise or recommending a heart-healthy diet like the Mediterranean diet. And it's just important to know that these risk calculators are very inaccurate. They don't apply to young individuals. They also don't apply to individuals with certain genetic defects that results in very high cholesterol levels. So when we plug all of our patients' information into this calculator, the patient will fall into one of four buckets. So they may be low risk, where their risk of a heart issue is between 0 and 5% over the next 10 years. They may be borderline or intermediate risk, where their risk is between 5 and 20% of experiencing an event over the next 10 years. Or they may be high risk, where their risk is greater than 20% of experiencing an event over the next 10 years. And if your patient falls into one of the outer buckets, life is a little bit easy because we kind of know what we should do. If they're low risk, we do lifestyle therapies. And if they're high risk, we do everything that we can to reduce their risk. Where there's some uncertainty is when a patient is borderline or intermediate risk. And the reason why there's some uncertainty is we know that in a large number of patients, the calculator overestimates their risk and they're actually low risk. And we also know in a large number of patients, the calculator underestimates their risk and they're actually high risk of experiencing an event. So there is something that's currently in the guidelines that we can do to try to further figure this out and try to further re-stratify our patient's risk. And that's actually going in and observing calcium in the blood vessel wall. And right now, how we do that is with a test called a cardiac CT, and we get a CAC score, which is an objective measure on how much calcium buildup is present in the heart arteries. And the idea is that if a CAC score is 0, we can re-stratify patients into a low-risk grouping. And if a CAC score is 100 or above, we would re-stratify that patient into a high-risk grouping. So the patient actually would come in for a separate test at the CT scanner, and they would have imaging done to look at their heart and their coronary arteries. And the image on the right, the bottom right, represents calcification in a coronary artery. And it's important to know that we're looking for subclinical atherosclerosis with this test. And within the artery wall, we're looking for calcification in the intimal layer of the artery. And that's going to be important later when I talk about some of my research, because the calcification that I've been examining is in a different layer of the artery called the medial layer of the artery. It's a non-contrast chest CT. The guidelines say that this really should be done in an asymptomatic patient who's in the primary prevention setting. And the score that we get is in the Agatston units, where the calcification area times density is measured. And as I mentioned prior, the score could be 0, which represents no calcium, and the Agatston units can increase as well as the coronary calcification increases. And it's generally accepted that a CAC score greater than 400 is severe calcification of the coronary artery. And really, the conceptual framework for identifying incidental calcification is that maybe risk factors for heart disease lead to calcification of the blood vessels that can be observed on an image test, and that this calcification may be present maybe many years before a cardiac event actually occurs, like a heart attack or a stroke. So, as I was mentioning before, there are some limitations to the coronary artery calcium score. It's an independent test, it requires additional resources, and it may actually increase the risk of certain complications. So we know that it requires time. We know that it's costly. This is typically not a test that's covered by insurance, so patients typically pay out of pocket for this test. It does come with additional radiation exposure. Some patients are unable to tolerate the test due to claustrophobia because they have to essentially be inside a CT scanner. It does require ECG stickers to be placed on the skin, and there are certain patients that have severe irritation to various adhesives. And it also increases the risk of incidental findings. And when I first started my medical training, I thought incidental findings were a good thing. I thought that, hey, if a patient had a certain test done and it identified some kind of mass, that maybe patients would be saved of cancer or cured of cancer, and we could potentially save their life. The further I've gone along in my cardiology training, I realized that a lot of times incidental findings cause significant harm, and we end up identifying benign nodules, and patients get a lot of invasive procedures. They have a lot of anxiety. Sometimes they have complications from biopsy, like a pneumothorax or a collapsed lung. And at the end of the day, the incidental finding was a benign finding that would have had, would have had no issues and would have never developed into cancer. So this got me and some of my collaborators and co-investigators interested in a different type of calcification, different from the coronary artery calcification. So this kind of calcification that we started looking into is called medial arterial calcification. And rather than being calcification in the intimal layer, it's calcification in the medial layer of an artery. And what we know is that this calcification can cause some hemodynamic compromise in the cardiovascular system. It can increase the risk of blood vessel stiffness. It can contribute to diastolic heart failure. It can contribute to elevated blood pressure as well. And it may contribute to an increased risk of atherosclerotic cardiovascular disease. The pathophysiology of medial artery calcification is different than intimal and may be related to abnormal calcium and phosphate homeostasis. And there's a lot that we don't understand about how this develops and what the mechanisms are for why it develops. We also don't have any therapeutic intervention for medial arterial calcification. I just wanted to take a moment to compare and contrast medial arterial calcification to intimal artery calcification and why it may be a useful tool for predicting cardiovascular disease. So medial arterial calcification develops a little earlier in life compared to intimal. So this is visible in middle-aged adults in their 40s, 50s, and 60s. We know that there are some risk factors for medial arterial calcification, and some of them are the same risk factors that we see for coronary artery disease. But one thing that we do know is that women have a higher prevalence of medial arterial calcification compared to men of a same age. We also know that menopausal women are more likely to develop medial arterial calcification, which may make it an ideal way to re-stratify women for cardiovascular disease. There's an older study showing that women who take hormone replacement therapy for menopausal symptoms are at a markedly reduced risk of developing medial arterial calcification compared to women who do not take hormone replacement therapy. As I mentioned before, medial arterial calcification is in a different spot than intimal layer calcification, and it contributes to increased stiffness of the blood vessels, but does not necessarily result in a blockage or narrowing of the lumen of the artery. And when we look at progression, it usually occurs earlier and progresses a little bit more slowly, and the coronary calcification develops a little bit later and usually worsens at a slightly more rapid rate. This is just a pictorial representation of where the calcification is present. So just as a reminder, the layers of the artery are the endothelium, the intima, the media, and the adventitia. The left figure represents calcification in the vascular smooth muscle cells. And the figure on the right represents calcification and plaque buildup in the intimal layer. And you can see there in the figure that this is resulting in narrowing of the lumen of the artery. Here's a CT scan of a patient with fairly extensive calcification. And this is just an example on how X-ray imaging can pick up on calcified blood vessels. And this particular patient has both medial arterial calcification and has intimal layer calcification. So the 3D image on the left is showing medial artery calcification present in the large blood vessels like the aorta and also in the blood vessels of the leg. And the image on the right is zoomed in on the coronary arteries. And this is showing calcification in the intimal layer of the coronary artery. So I'm going to now move into some of the research that I'm doing and some of the areas that we're taking this research. So we asked ourselves the question, is there an additional imaging test that could provide insight on medial arterial calcification that overcomes the current barriers that exist with the coronary artery score or the CAC score? So medium-sized arteries in the breast can become calcified, and it calcifies in a medial arterial calcification distribution. And this medial artery calcification is visible on a mammogram, which uses X-ray. And this is called a breast arterial calcification. The figure on the left is showing that medium-sized arteries in the breast are present and that they can become calcified. And the mammogram image on the right is showing that this calcification is present and it can be present with differing severity. So the panel on the left is showing densely calcified arteries, and the panel on the right is showing more punctate calcifications, which is a little less severe. And this breast artery calcification is not typically reported on radiology reports because there is no known association between BAC and breast cancer. And what I will say is this makes it particularly difficult to study because if you wanted to study this calcification, you have to go back to the images themselves to study it. You can't rely on the radiology reports, and there's also no like ICD-10 code or ICD-9 code that you could rely on to try to determine if a patient has this calcification or not. So we developed the hypothesis that mammography for breast cancer screening may be an important and emerging tool for risk stratification in women, and it may overcome the prior barriers. This BAC is not present in all women. There's some research that it could be present in up to 20% of screening mammograms, about 1 in 5. We took a look at all of the literature that's available on this topic, and there'll be more on this later, but essentially all of the research on this topic is of very low quality and a very high risk of bias. Most of the available literature is cross-sectional in nature. So we determined that there's a further need to study this topic, as very few high-quality prospective studies exist. The panel on the right just shows varying degrees of this medial arterial calcification and how it can be detected on a mammogram that uses X-ray. The top panel represents no calcification, and then there's mild, moderate, and severe calcification represented on the next 3 panels. So one of my research mentors and I, we enrolled a cohort of women with and without breast artery calcification. And these women were enrolled at an institution different than Penn State, but we are still following these women, and the study is IRB approved here at Penn State as well now. So we enrolled 1,995 women who were arriving for a screening mammogram at an outpatient radiology center, and we specifically were analyzing women with no known clinical ASCVD. We had the radiologists at this outpatient radiology center document whether or not a BAC was present. So this was determined by the radiologist, and they determined just a very simple yes versus no. And the reason why I emphasize that is that there are some researchers that are trying to determine severity of this calcification and whether or not more severe calcification associates with more severe cardiovascular disease, but that was not something that we looked at here. So we did a small test study with these radiologists. We had them analyze a test set of mammograms. There were 20 of them, and 12 of them had no back, and 8 of them had back. And we essentially determined that they were able to accurately identify this and that there was 96% agreement between the total 420 reads for back prevalence. The outcomes of interest for this study, one was coronary artery disease, and we determined this as a composite outcome. So we looked at self-reported angina, which is chest pain related to narrowing of an artery, myocardial infarction or heart attack, any report of abnormal coronary angiography with narrowings or blockages in any heart arteries, and also coronary revascularization, which we defined as a CABG or coronary artery bypass graft surgery or a stent placement, which is PCI or percutaneous intervention. We also assessed for the outcome of stroke as well, and we technically did not limit it to just ischemic stroke, so this is ischemic or hemorrhagic stroke. And we also followed these patients for the development of cardiovascular disease risk factors as well, like high blood pressure, high cholesterol, diabetes, and we also periodically assess their smoking status as well. So this is the flow diagram for this study. We initially screened over 2,000 women, 1,995 women enrolled. We ended up following these patients for up to 10 years, and it was really hard to not lose patients to follow-up, but we had a team of students and other research staff who were able to follow these patients. And at the 10-year mark, we were able to analyze 1,001 women who had no prior ASCVD at baseline for the development of risk factors and cardiovascular disease events. So here's the baseline characteristics table. The left panel represents those women who had a BAC present, and the right panel represents those women who did not have a BAC present on their baseline mammogram. You can see that women with a BAC were more likely to be older. Of medical comorbidities, the most common was high blood pressure, followed by high cholesterol. Also, among women with a BAC present, close to 90% of them were menopausal. Among women with no BAC present, about 52% of them were menopausal. We also assessed for baseline ASCVD, and you could see that a small number of participants had ASCVD at baseline. But for some of the analyses, we excluded these participants because we were interested in the primary prevention population. So here are some of the results on what we found. Now, the left panel represents ASCVD events. The x-axis there is years, going from baseline up to 10 years. The y-axis of the figure is cumulative percent without an ASCVD event. The blue line represents those without a BAC present, and the purple line represents those women with a BAC present. And you can see that women with BAC were more likely to develop ASCVD over the next 10 years compared to women without a BAC. We also looked at risk factors as well, and that's represented on the right panel. And interestingly, women with a BAC were not more likely to develop more CVD risk factors over those next 10 years. So we controlled for the common cardiovascular disease risk factors, but we hypothesized that BAC was contributing, or this medial artery calcification was contributing to the development of cardiovascular disease independent of the traditional risk factors. So when we actually looked at coronary artery disease, we saw that there was a more than threefold increased risk of ASCVD when a BAC was present. And when we looked at stroke, there was a more than fivefold increased risk in stroke when a BAC was present over 10 years. There were a lot of limitations to this study. This study was done with essentially very minimal funding. So there was a lot of missing data. There was lack of diversity in the participant pool. Also, this relied on self-report, which comes with its own biases as well. Now, one other thing that we did with this study is we looked at baseline traditional cardiovascular disease risk factors like family history, age, high cholesterol, high blood pressure, and we looked at what kind of association do these traditional risk factors have with the development of coronary artery disease over the next 10 years. And then we looked at BAC. And essentially what we found was that this medial artery calcification had the strongest association with cardiovascular disease events compared to the traditional risk factors that we rely on. Now, the next two slides, I'm just going to highlight two other studies that have been published on this topic that I'm not involved with. And part of the reason I wanted to highlight them is each of these studies highlight a different method of determining BAC presence. So the study that I was involved in relied on a radiologist to report it, but these next two studies rely on slightly different methods. So this study is called the Minerva study, and this was published by a group in California. And they enrolled over 5,000 women with a mammogram, and they followed them for 6.5 years. And they utilized a densitometry technique where they used X-ray to actually measure the mass of medial artery calcification, and they were able to produce an objective continuous measure of BAC, sort of like how the coronary artery calcium score is reported in Agatston units. They looked at a total cardiovascular disease outcome and also a more specific atherosclerotic cardiovascular disease outcome. And they also found an increased risk of BAC with ASCVD and also total CVD. And when they actually looked at their severity measures, they did not find a dose-response relationship between more severe BAC and cardiovascular disease. And they ended up adding their back mass measurement to the calculator that I had spoken to earlier, and they actually found that this improved the accuracy of the calculator, which is interesting. The second study is a study that was just recently published a couple months ago in JACC Advances, and rather than relying on a radiologist or a densitometry technique, this study relied on a machine learning program to determine whether or not a BAC was present, and they looked at all-cause mortality and also cardiovascular disease. They found a back prevalence of 23%, so a little bit higher than that 20% that I had cited earlier. They also found an increased risk between BAC and all-cause mortality and also cardiovascular disease. And they also found that more severe back was associated with more severe or a higher risk of death in cardiovascular disease. So this is just the last portion of my talk. So we also systematically analyzed all of the literature related to BAC and cardiovascular disease. This data was presented at the last year's American College of Cardiology meeting, but it's not published quite yet. So some medical students here at the Penn State College of Medicine and I ended up doing this study because we were really interested in just systematically understanding what the literature is on BAC and cardiovascular disease. So we identified that there are 46 studies that are out there. And these studies include more than 68,000 women. The weighted mean age of women included in these studies was 60.5 years. And of all of the studies together, back prevalence was 17.1%. We identified that there are 5 prospective cohort studies. Now, not all 5 of those actually assessed hard cardiovascular events. Only 2 did. There were 9 retrospective cohort studies. There was 1 case control study. And as I mentioned earlier, the overwhelming majority of study types available on this topic, they're cross-sectional in nature, greater than 66%. So we systematically graded all of these studies for bias. We used the Newcastle-Ottawa scale, which is a grading scale for observational studies. So we broke the studies into 2 groups, the cross-sectional studies and also the cohort studies. We assessed the studies for bias in the domain of outcome, comparability, and selection. The green box represents the percent of studies that are at low risk of bias for those certain domains. The yellow box represents those studies that are at a possible risk or even an intermediate risk of bias in those domains, and what percent of studies are those represented by. And the red box represents those studies that are at a high risk of bias. And what you can see here is that these studies are fairly highly flawed. When it comes to the outcome of cardiovascular disease, close to 90% of the available studies are at a high risk of bias. The domain where there's the least amount of bias is in comparability, comparing BAC to no BAC. And these studies are also at a high risk of selection bias as well, which can be seen. We also analyzed the cohort studies for bias as well. And there's a little bit less bias in the cohort studies compared to the cross-sectional studies, but the overall conclusion is the same, is that these studies are still at a high risk of bias, most specifically in the area of outcome ascertainment and comparison of outcomes between studies. We also pooled the data as well. So this is pooled data from the cohort studies only. And we looked at various cardiovascular disease events. Most of them were statistically significant other than myocardial infarction. Now, the effect estimate was increased for myocardial infarction with a BAC, but this did not meet statistical significance. The other interesting thing here is that this medial arterial calcification also increased the risk of congestive heart failure as well. And the risk ratio was 2.14. And I suspect this is due to increased blood vessel stiffness and vascular stiffness contributing to diastolic dysfunction, but I'm not quite sure. And the other interesting thing is that BAC associated with an increased risk of all-cause mortality as well. And the risk ratio there is 2.04. And the average follow-up time of these cohort studies was 10.5 years. And this makes me think the association with all-cause mortality, could medial arterial calcification be playing a role in other disease processes other than cardiovascular disease? We're not quite sure. And then we also analyzed all of the cross-sectional studies together and looked at BAC and a history of cardiovascular disease risk factors. And the one thing that was interesting here is that from a cross-sectional standpoint, patients who self-report smoking are actually less likely to have a BAC present. But we think that this could be due to survivor bias or something like that, because we know that smoking is a potent risk factor for the development of heart attack and stroke. So just to kind of wrap up here, I wanted to talk about some of the future directions where some of this research may be going. So we're looking into potentially validating this on a larger scale in diverse populations. I'm doing some work right now with the Women's Health Initiative, which is a large-scale national health study in women, where we're having some mammograms that were collected in the WHI, analyzed for this medial artery calcification. This may ensure that there's some diverse populations being represented, and this may improve some of the generalizability of these findings. Some studies have started to do this, but integrating this medial artery calcification into some risk models may be important and may be the future of where this research work is going towards. Machine learning and artificial intelligence is kind of increasing at a fairly rapid rate, especially in the area of BAC detection. So I definitely think that this is a future direction of this work, because it's going to automate the detection. And I'm working with a company that has a machine learning program for detecting this calcification, and that may be an area of future research as well. But one thing that's important is considering how we implement artificial intelligence. How do we reduce biases with artificial intelligence in cardiac risk assessment? And how do we ensure that this is reliable across different socioeconomic groups and diverse patient populations? I think that's definitely an area that this work is going to be heading towards. And the other thing is there's also an opportunity for this kind of research work to move a step back in the translational science spectrum, more in the T0 area. There's very minimal information that we have on the underlying pathophysiology of medial artery calcification. What role does genetics play into the development of this medial artery calcification? I recently submitted a grant with some co-investigators that ended up not getting funded, but we were looking at we were proposing to look at different genetic defects and what role that may have in medial arterial calcification. So just the key points of this presentation: the traditional risk factors for cardiovascular disease, they don't fully account for sex-specific differences in outcomes. There are emerging risk-enhancing factors for cardiovascular disease, especially women, such as preeclampsia, premature menopause. A breast arterial calcification may be a risk-enhancing factor for ASCVD. We know that a BAC is visible on a mammogram, and it correlates with an increased risk of coronary artery disease and stroke. And unlike coronary artery calcium, BAC may offer a low-cost, radiation-free alternative to re-stratifying cardiovascular disease risk in women. And as I mentioned, artificial intelligence may be the future for BAC detection. So, all right, thank you, and I'll take any questions that you may have.
Thank you so much, Dr. Nudy, for this presentation. It was so interesting and so informative. It looks like we have a question in the chat. Would having dense breast tissue affect the detection of breast artery calcification on a mammogram?
So that is an excellent question. I hypothesize that the answer is yes. But that's actually that's actually a research question that we are going to investigate when we do this work with the Women's Health Initiative. So we're actually going to try and assess whether or not breast density interferes with the ability to detect BAC. So what I will say is stay tuned there. There may be more to come on that topic in the future.
Do we have any other questions? You can put it in the chat or feel free to unmute yourself to ask a question. Let's see, another question that came in is that earlier you were talking about the CAC scan not being covered by insurance. Are there other alternatives now that people can use?
Yeah, so that's a good question. So the answer is no. There is not a guideline-based alternative. Now, part of the reason a CAC scan is not covered by insurance is that there's really no large-scale clinical trial or randomized clinical trial showing that a CAC scan improves any kind of outcome. So there is an organization called the USPSTF. And they reviewed the literature on CAC, and they actually assigned it an I level of recommendation, meaning that insufficient evidence exists to recommend its use. So that's actually the main reason why insurance doesn't cover it. Most patients are paying out of pocket like $200 to $250. I know the price of it has come down quite a bit in recent years. But yeah.
Okay, well, if nobody has any other questions, again, we'll thank you, Dr. Nudy, for presenting this information. And thank you for your engagement, for participation. And if any of you on the call have a topic that you would like to share in a translational science seminar, please reach out to me via email, and I will put my email in the chat. You'll be getting all of the materials sent to your email, along with a survey for quality improvement. So please make sure that you do complete that. And with that, we'll thank you, Dr. Nudy, and we'll see you later.
Thank you so much.
Bye-bye.